Assalamu alaikum and good morning. And thank you, Chair, for the kind introduction. First, I'd like to thank the organizing committee for the kind invitation. So, what I have been asked to cover, I've been asked to just share with you recent data which might improve the clinical practice, and then what ARV in the pipeline, and then a bit of resistance as well, and then very few words about HIV cure, and then finally talk about HIV care, how to individualize the care, but yet provide a holistic care. So I'm afraid few of the first three parts are data heavy, but on purpose, I'm going to whiz through the numbers, but just to give you kind of really the takeaway from that, just for the sake of the time, so we can allow more time for discussion if possible. So the first one is, we all know about the integrase inhibitors, you know, the long-acting integrase, the cabotegravir with rilpivirine. So it was licensed in 2021 for 4-weekly injection, and then in 2022 for 8-weekly injection. So we all got excited, but obviously you can only use for suppressed patients. So you can't, the guidance, you use it for someone who's suppressed, someone who's engaged in care, and someone who's willing to come for frequent visits. You can't use it if there's any resistance. You cannot use it if there's any history of failure. And obviously, you can't use it if it's a hepatitis B infection. Right, so what is recent data? This is data from CROI in March this year. And what they wanted to look at, can we use this combination in people who are not suppressed, or people who really the clinician would like help with? This is people who really can't take the oral tablets. So what they did, they had about 400 patients, and in the first few weeks of the study, they tried to give them financial incentive to support the adherence, and they were hoping that to get them suppressed as much as they can, and then randomize them to either give them long-acting injectables or to continue the oral therapy. So as you can see, it's still 17%, despite the support, 17% remain viremic. So effectively failing treatment with a viral load more than 200. Despite that, the Data and Safety Monitoring Board stopped the study because the long-acting injectable showed superiority. As you can see, the failure only 6% compared to 28% on the standard of care. So the question is, and now this is the IAS guidelines. This is not the DHHS guidelines. So now they say if the clock is ticking and you have someone who's very sick and a viral load, very high CD4 count, low 200, and their risk of disease progression, you can use this if you have a very good support. So you can bring them to the clinic, or you can even go to the community and give them the injection. So just something to need to think about, because the risk of this long-acting, if they run out and they don't come for the appointment, the tail off of these medications is very long. And rilpivirine was detected even after, up to 1 year after the last injection. So potentially they can develop resistance to either rilpivirine or cabotegravir. So that's the first one. There is a very elegant study from Africa, because the long-acting injectable is still not licensed by the WHO in Africa. And this study was done in 4 African countries. So they wanted to see, can we do this as a public health approach? So you don't really, monitor them every 3 months as stringent as in the clinical trials, but you monitor them from a public health approach. So you do viral load every 6 months. So it's again a big study, and as you can see, they're females, but what they did not do resistant test at baseline, but what they had a proviral DNA data, and they analyzed that after the study was concluded. And the data showed that about 10% of the patient had archive rilpivirine resistance, 8% had archive cabotegravir resistance. Despite that, you can see it's a very impressive response. So now the question is, if you have someone with archive mutations, can you use that? I think probably probably I wouldn't do that because the rilpivirine mutation archive were shown in the licensing study. Atlas and Flare showed that it was a predictor of treatment failure. But it is very reassuring, but we need to wait for more long-term data. But it was very interesting data. Another data regarding a long-acting, the last one. This is a patient. Patients are very difficult to treat, and they can only take injectables, but they have a non-nuke mutation. So you can't use capitegravir and rilpivirine as licensed. So this is a study, a very small number for many clinics in the States. And what they did, they used off-label use capitegravir with a capsid inhibitor, which I'll show you the data for. This capsid inhibitor, you give it every 6 months. It is the first in class, and it's licensed for people who are heavily treated. These patients are not heavily treated, but they can't take oral, and you can't give them the capitegravir rilpivirine. So what they did, they gave them the capitegravir minus plus rilpivirine and lenacapavir. And as you can see, it's again, the data is very good, 94% viral suppression. So if you have some difficult patients to treat, I mean, these data can just give you a bit of courage to use that approach with them. This is data. We all know that the bictegravir and dolutegravir, both of them are as substrate of cytochrome P45. So any inducer will reduce the level. This is why the guidelines suggest if you use dolutegravir in someone who's on rifampicin, you need to use a double dose. For the bictegravir, before this data, what the guidelines suggested that it's contraindicated if someone takes rifampicin, and that was based on the data from healthy volunteers. So when they use rifampicin with bictegravir in healthy volunteers, the level of bictegravir reduced significantly. So now they try to see, can we double the dose? So what they did here, they have patients on TB, rifampicin, and they double the dose of Biktarvy. So you get double the dose, and this is compared to patients who are taking dolutegravir BD. And what they wanted to see, they wanted to see two things. Will we achieve viral load suppression, or will we achieve a very low of bictegravir? The data was very encouraging. As you can see, the viral load suppression was very good. So both of them 95% in the bictegravir and in dolutegravir arm. But also, when you look at the trough level, although on the far right you can see that's the data from bictegravir OD with rifampicin. That you can see without rifampicin, you see the level was very high. But here with rifampicin, the level goes up the trough, but is still in the therapeutic range. So I believe, again, if you have a patient who really doesn't want to switch, I mean, it's not in the guidelines yet, but I suspect more data will come, and that's probably in the guidelines will get changed. And then this, I'm not going to talk about this. I think Dr. Moayed did this beautifully yesterday. It's about using the statin in patients who are HIV positive, and the guidelines already changed. So if you have a patient who's over 40, HIV positive, with low to moderate risk factor, using a moderate intensity statin, I think what is available here is very likely to be atorvastatin and rosuvastatin. So using that is likely to reduce the risk of myocardial infarction and death by 20 to 30%. That's something, it's again, I think probably not in the Saudi guidelines yet, but that's something you need to consider. I think this data was from IAS 2023, and this is a new WHO guidelines regarding U equals U. I think we knew about that the viral load is the main parameter or the main indicator for HIV transmission, and the higher the viral load, the more infectious the patient is. We're talking about the sexual transmission. And the U equals U, 2017, everyone agreed if a patient is taking treatment, viral load less than 200 is not, we don't talk about less than 20. So U equals U says, if someone takes treatment and adhering to the treatment and viral load is below 200, over 6 months, they're not infectious. So the risk is zero. But what the WHO, they looked at what about the risk of the transmission in patients who have a higher viral load than that? And they did a beautiful systemic review, and it's published in the Lancet. You can look at it. And what they noticed that they looked at all the studies which looked at this. I think they had 80 studies in that review, and there were 323 transmissions, and only 2 of them happened in a viral load below 1,000. One of them like 600, one of them is 800. And those 2 cases, there was almost 2 months from the last viral load and the transmission time. And they also some possibility of low adherence. So what the WHO now said, if a viral load below 1,000, the risk is almost 0. I'm not saying that you go and tell your patients your viral load is 600, 800, you're not going to transmit. But I feel like it will give you more assurance about U equals U, because I believe some people still, they feel very anxious if you have someone who's been suppressed for 5, 10 years and they want to conceive, they still feel very anxious about telling them you're not infectious. So this is, I think it's a very interesting data. Moving on to the pipeline. Obviously, you all know this, since the AZT, we have come a long way, but people are still looking for new drugs and for new strategy, mainly long-acting. This is data presented at CROI again this year. So what they wanted, they're looking for a drug to pair it with lenacapavir. Obviously, for the 6-monthly, initially they wanted to pair it with islatravir, but unfortunately, at a higher dose, islatravir, it's one of the MSD drugs. It is a nucleoside reverse translocation inhibitor. At a higher dose, it does increase the CD4 count, and the studies were stopped. However, at a lower dose, it doesn't. So, and I think it was one of the really blow for the capsid inhibitor, because that was the hope that to get 2 drugs long-acting every 6 months. But now what they're trying it orally weekly. So they did this study, a switch study. As you can see, the data is really very good. Whether you go standard of care, whether you give people lenacapavir, capsid inhibitor, islatravir, the response is very good. Most importantly, there is no significant reduction in the CD4 count. So I think that would be, I think I'm really looking forward to more data of this. So can you imagine give patients 52 tablets, that's for 1 year. So it's very easy for confidentiality, for people who are traveling, for storage. Lots of patients say, doctor, I can't take 6 months, I'm traveling for 6 months. So I think this will really be a game changer. Right. So there's 2 more very early studies. It's just more of a dosing study, more of efficacy study. This is an integrase inhibitor from Gilead. And this is also another NRTTI from Merck. And both of them for a weekly dosing, and both of them showing more than 1 log drop after 1 week. Right. So broadly neutralizing antibodies, you can use them to neutralize HIV like any antiretroviral therapy, but also they have a role in HIV cure because they can reduce the reservoir and they can induce the immune response against the virus. And this is data again from CROI. So you can see the first study, BNAbs were using in isolation. In the second one that was used with the cabotegravir. The third one was used, 2 of them used with the capsid inhibitor. And the last one, 3 of them used together. So they're using them in different combinations. And the data so far is still very early, phase 2 study, small number of patients, but most of them were switched. But the data again is very promising. So that's again will be coming in the pipeline. And also people are looking at novel injectables, like you give cabotegravir or pivoring and nanoformulation every 6 to every 12 months. People looking at implants. So people looking at patches as well. So I think the future is very bright, and I think that will continue. Right. So moving on to the heavily treatment experienced patients. So I hope you don't have many patients like that. So you can see this is a real patient. So basically over the years is lost pretty much everything. So all the nukes, you can see all the mutations. The non-nuke, you can see the PI, significant mutation, and integrase as well. So what options do we have? And I think these patients, I think the key thing is, from a practical point of view, try to avoid reaching that point. And I think, and try to think of a patient more of a holistic approach rather than just medications. And don't change patients who's failing treatment. Personally, I never do that. If I don't know why the patient failed on that. Why? The issue of adherence and fix it. I think changing the medications, you're just treating yourself. So without, and I understand there's some difficult patients, no matter what you do, they will fail. So we have to accept defeat for that. But most of the patients, if you really know the reason for poor adherence, is it denial? Is it disclosure issue? Is it side effects? Is it mental health? Is it lack of support? Is it depression? What? So once you find that and fix it, then things can work. So we have, in some of these cases, you can still use dolutegravir BD, you can still use drunavir BD. But I think the three drugs you can see there on the far right, there. So you can see fostemsavir, eculizumab, and lenacapavir, the capsid inhibitor. These three drugs, they were tried in studies, and they're very similar. So usually you give these drugs because they're new. So the FDA would demand from the company that to show that it does work alone, like 10 days, significant viral load drop, and then you do randomization. So three similar studies. You can see this is a bright study for fostemsavir. It is an attachment inhibitor, just while the virus coming in. And you can see 60% viral load suppression. This is eculizumab. It is infusion every 2 weeks. It's again 56% suppression. And this is the capsid inhibitor. Again, 83% viral load suppression at 90, I think 52 weeks, and then 100 weeks, the viral load suppression. So obviously it's smaller than what you get, but these are very difficult to treat patients. Right. Very quick words about cure. I think the question is, do we need it? Sorry. So by show of hands, who thinks that we need it? We need cure for HIV. We have all these fantastic medications, and I'm glad most of you agree. Obviously, we still see toxicity, we still have immune activation, still people have cardiovascular disease. Access to treatment is not, universal. Economic burden. Most importantly, patient would like that. And often you see someone positive for 15 years, doctor, is there any cure? And I think more to do with the stigma discrimination, not just because he's taking medications, just a single tablet. So I think that's really, and obviously we have the classic cure, eradication, you have the functional cure, you stop the treatment, the there, but it's not rebounding. And this is a study which looked at the viral load suppression. As you can see, 6 months after the treatment, viral load becomes undetectable. And as time goes on, the decay will continue, but it plateaus. But most importantly, once you stop the treatment, 2 weeks later, the viral load rebound. So people at that time felt cure was impossible because they discovered their reservoir, because the patients, the virus, once it goes into the cells, they can either replicate and continue to infect cells or goes into latency just by random. And until Timothy Brown, who died in 2020, this is from, I think all Berlin patient, happened to have acute myeloid leukemia. So how was he cured? He had the leukemia, part of that, he had a total body irradiation, and then he developed graft versus host reaction, and that killed all his cells. But the bone marrow transplant happened to be from a patient who has got the mutation Delta 32, which makes the cells resistant to HIV. So all the new cells were resistant to HIV. Treatment to stop, patient until he died, no evidence of HIV at all. So he was cured. And since that time, there were many cases of bone marrow transplant, very similar cases. And actually 2 cases were just elite controllers, but naturally they clear the virus. So not just your viral load, but when they looked at DNAs also, there was no virus at all. And these are the barriers, because the virus hides on all these tissues in the latent cells. They're very diverse. So if you want to have a policy to target that, you need to target all these tissues. And these are strategies which we have at the moment. And unfortunately, none of them is really proven really effective. So they're very modest. And the way forward, that is to go for combination. How am I doing with time, Chair? 5 minutes? 3? 5 and 3? 2, 3? She said 5. Okay. So, okay, the question. So I'll do in 2. Yeah, great. Right. So the final one is about we have all these fantastic medications, but still we don't have a cure. So meanwhile, while waiting for that cure, that holy grail, I think what we need to do, we need to do as best as we can when it comes to caring patients. And I think I can't emphasize enough that we need to do patient center, patient center, patient center. And this is WHO guidelines. You need to just not focus on the disease. You need to focus on mental health problems, but also when you do personalized treatment approach, patients are more likely to feel part of it, empowered. They're more likely to adhere to the medications. And just remember one thing, these patients, when they come to us, pretty much everything has been taken away from them. They probably were tested without knowing, so no one took the consent. Probably someone told their employer already, someone already told their wife before coming to you. And when they come to you, you have an opportunity. So you either make or break it. So if you embrace them, respect them, and work with them, you really, it will make your life easier without any judgment. And this is the mental health. It's very common, depression, anxiety, and we worry about that because it does impact the whole cascade of care. And the best way is to integrate mental health in our routine. Screen people, you find them having anything, refer them on. Stigma, again, it causes all the issues, emotional distress, but it causes anxiety, depression, and also, like the mental health problems, is likely to impact all the cascade from testing to viral suppression. And this is how we eliminate the stigma, or at least how we can tackle stigma, educate the public, dispel the myth about HIV. But more importantly, you need to have policy to protect patients' rights and empower patients as well. But also do not forget, because if you ask someone, take medications, but they don't have work, they can't feed their kids, they don't have a housing issue. So clearly the priority is different. So addressing all of that is very crucial. So finally, as you can see, HIV, I think it's fascinating. It continues to evolve, lots of research, treatment in the pipeline is anything but dry, and viral suppression in heavily treatment experienced patients is still possible with the medications, but they need an MDT approach and support. HIV cure is needed, but I feel like it still remains elusive. And finally, HIV care really should be holistic, but yet individualized. And by that, thank you very much.